And so for our next segment, Dr. Sue will now introduce our next speaker, Dr. Ajay Nuka. Dr. Nuka was unfortunately not able to join us live, but did pre-record his presentation for us.
Great. Well, Dr. Ajay Nuka is an associate professor, serves as director of the myeloma program in the Department of Hematology and Medical Oncology at Emory University School of Medicine. He serves as medical director of the Winship Data and Technology Applications Shared Resource at Winship Cancer Institute of Emory University. And his interests as a clinical investigator focus on multiple myeloma and bone marrow transplant. His research interests include integrating genomic and clinical data on a uniform platform to risk stratify myeloma and to evaluate newer myeloma therapeutic strategies aimed at prolonging survival in myeloma patients. So we're happy to have at least his recorded talk.
Hi, my name is Ajay Nuka. I'm an associate professor in the Department of Hematology and Oncology at the Emory University Winship Cancer Institute. In the theme of moving towards acute and multiple myeloma, I will be discussing the role of measurable residual disease testing or minimal residual disease testing in myeloma and the quest for cure. I'll start my presentation with two cases to give you the complexity involved in making decisions based on the minimal residual disease testing. Case number one, this is a 66-year-old gentleman who presented with IgG kappa myeloma with an elevated total protein and anemia. Speed to microglobin was 8.5 at the time of diagnosis. He has an ISS stage 3 disease. Bone marrow biopsy showed 80% cellularity. Plasma cells constituting 50% of the cellularity. Fish did not show any high-risk features. He received the induction therapy with RVD for 4 cycles, went on to achieve a VGPR pre-transplant. And after transplant, he achieved a PET negative stringent complete response. Mind you, this is 2012. So he started on len maintenance at the time. And by the time the MRD testing was available at good sensitivity of 10 to the power of -6, this is 5 years later. So sometime in 2017, when we tested his MRD by clonoSEQ, his MRD status was negative. So ever since, he continues to obtain an annual MRD testing whenever he goes for his annual bone marrow biopsy, and he remained negative, and he still continues the lenalidomide maintenance. Patient number 2. This is a 66-year-old gentleman with free lambda light chain multiple myeloma, presented with anemia and hypercalcemia, presented with a ISS stage 3 disease. He had a cellularity of 95% at the time of his diagnosis, and fish showed deletion 17p and translocation 414. Got the standard induction therapy with RVD for 4 cycles, went on to achieve his beautiful response, a stringent complete response prior to the transplant, and post-transplant, he attained a MRD negative stringent complete response. He went on to a 3-drug maintenance therapy, similar to what we use for our high-risk patients. And a year after his transplant, when we were doing his annual restaging, he was found to have MRD positivity by NGS at 10 to the power of -6. So we did not change his treatment at the time based on his MRD positivity, fully understanding that this could be a harbinger for relapse, which was not a surprise. 6 months later, he was progressing. And when he had a biochemical progression, we started him on daratumumab, pomalidomide, and dexamethasone. Later, he had a progression in June of 2019, underwent a clinical trial using the BCMA-directed CAR-T, did not get a huge response. So 4 months later, he was started on KCD, went on to further clinical trials with belantamab, a CD47 monoclonal antibody, and more recently, a clinical trial with a BCMA-directed bispecific antibody that is allowing for prior BCMA exposures, and the patient continues to stay in remission. The biggest question that comes to both of us, to all of us in both these patients is, number one, is there a role for using the next generation sequencing to stop off the maintenance in patient number 1? And in patient number 2, when we're seeing an MRD positivity sometime a year after the transplant, is this a time for us to intervene to push him back into an MRD negative state? We do not have data at this time, but what I'll be doing over the next 30 minutes is to go over what are the pros and cons of each of these approaches and where we are leading, where we are headed towards in terms of the clinical trials that are gathering much of this data. So in today's talk, I'd like to outline MRD as a prognostic marker for both progression-free survival as well as overall survival. I'll be presenting data from a prospective trial, data from meta-analysis, both showing that MRD is a good prognostic marker for both the PFS as well as overall survival. And when we talk about MRD, there are several ways of how to measure this MRD: the next generation sequencing, next generation flow, mass spectrometric methods. Which is more superior to the other? I'll provide you the contrast between each of these processes and how these are done. What are the pros and cons of each of these approaches? The next one is talking about defining MRD negativity. When you say MRD negative, it does not mean to me anything. There should be a threshold. What is the threshold of MRD negativity that we are desiring for the specific patient? MRD, the most sensitive techniques like the NGS and the NGF are offering MRD negativity, able to measure the MRD negativity to a threshold of 10 to the power of -6. That is the ability to detect 1 myeloma cell in 1 million bone marrow cells. So how can we define better, how can we make these testings with MRD, which is a measure of the myeloma status inside the bone marrow? That does not mean that there is marrow outside the bone marrow. And current techniques of using MRD do not incorporate any imaging. So can we, by incorporating imaging to MRD, can we make it more refined? And would this be able to give us a better, more robust prognostication? And one of the things I'd like to discuss is the MRD-guided therapeutic decision-making. So you saw two cases where in one case, we're trying to de-escalate the treatment, the other one to escalate the treatment. And what is the controversy at this time, and what is the data that we have gathering so that we'd be able to make those right decisions backed up by data. And I'll end up with trials in the progress as well as the usage of MRD as a regulatory endpoint as well. So let's start with the first concept of using prognostic. What is the prognostic value of MRD in multiple myeloma? So this is a meta-analysis that was published by Dr. Nikhil Munshi, and they used 44 studies that tested for PFS as an endpoint and 23 studies that had overall survival as an endpoint. And what they looked at was, without taking any threshold into consideration, if the patients had MRD reported as positive or negative, they were taken into the study. So from the PFS perspective, there are close to 8,000 patients that enrolled into the trial. And clearly, as you can see, the MRD negative status was able to prognosticate that these patients will stay in remission for much longer time compared to those patients that were MRD positive. So MRD negative is prognostic for PFS. The hazards ratio is 0.34, which means a 66% reduction in the risk of progression or death. To the right side, you see the overall survival. And here the hazards ratios are much more smaller. So the hazards ratio is 0.28 for overall survival among these 4,000 patients from 22 trials. And here the 0.28, which is equivalent to a 72% reduction in the risk of progression for a risk of death for these patients, showing that MRD negativity is prognostic for overall survival. So now moving towards using these in the upfront setting and in the relapse setting as well. So these are the results from two upfront trials at Alcyone and Maya, which use daratumumab combinations in the upfront compared to non-daratumumab combinations for transplant ineligible patients. So at an MRD status of 10 to the power of -5, patients who achieved a greater than CR and MRD negative had much robust, better prognostication with 48-month PFS at 70%, whereas patients who were either achieved a very good partial response or lesser, or they were MRD positive at 10 to the power of -5, they did not have the same outcomes. So clearly, you're seeing a combination of the Pollux, Castor, Alcyone, and Maya trials, all of these suggesting, even if you break them down by upfront and relapse refractory studies, these are the exact graphs that you're seeing. So looking at the Kaplan markers for patients who achieve greater than CR and MRD negative is, again, much more robustly prognostic than those patients who achieve greater than CR but MRD positive. So clearly it is showing that the deeper the response that you're able to obtain for these patients, you're able to maintain their remission status much farther and much longer. So coming to the question of what is NGS? So the genes for the receptors of each T cell and B cell undergo VDJ recombination. So this permits for extensive diversity in the immune system repertoire. So the diversity is introduced by the insertions or deletions of random nucleotides, and the CDR3 coding region is the highly diverse region of receptor protein, and this is the key determinant for the antigen specificity. So the unique DNA sequences that are formed as a result can be used to identify a B cell or a T cell. So here the NGS MRD uses PCR and NGS to identify the DNA sequences of the B cells and the T cell binding receptors, and the multiplex primers are designed to get the consensus sequences within these diversity gene segments, and clonoSEQ leverages the PCR and the NGS to identify and quantify these rearranged and translocated receptor gene sequences. So in a healthy cell, in a healthy individual, the population of normal B cells or T cells have normal receptors which correspond to the diverse mixture of the DNA sequences. In a individual with a malignant B cell or T cell malignancies, the dominant sequences are identifiable and quantifiable. So the NGS detects all the malignant cells associated with the tumor, and it is retained over time as the barcode of a quantifiable molecular barcode is trackable. What you're seeing as the sequences at the initial diagnosis are tracked over time. It also helps us to directly measure the cancer cell burden at any given time throughout the clinical management. So usage of NGS in the clinical setting was proven in the IFM 2009 trial, where patients were under the age of 65. 700 of them were randomized to receive RVD upfront, RVD followed by R maintenance, or RVD followed by transplant upfront, and then patients went on to receive the maintenance. If you look at the PFS1 benefit, the TFS1 benefit was favoring the transplant arm with a benefit of more than a year for the PFS1. If you look at the MRD negative rates, in the bottom right corner, you're able to see the MRD negative rates are much higher in the patients that underwent a transplant at 30% at 10 to the power of -5, compared to 20% in those patients that received RVD alone. Look at the bottom left corner. So this is the PFS by the MRD status. This is a longer follow-up that was done for this study of close to 90 months. And the topmost curve are the patients, which is not a surprise for us. These are the patients who were MRD negative at the time of it, MRD negative that underwent a transplant. The second curve are MRD negative at 10 to the power of -5 that did not undergo a transplant. Transplant helps probably with a better quality of MRD negativity for us based on what we are seeing here. As can be expected, those patients who are MRD positive, either with a transplant or without a transplant, did not do well in this group. So MRD again was prognostic in a prospective trial, And clearly, these patients tend to do much better if they achieve MRD. And this is provocative, especially with the results that were present at the determination trial, that PFS1 is clearly favoring the patients who undergo a transplant, but the overall survival was not existing. And should you offer transplant or not? And in my opinion, I always want to show this as an endpoint, that PFS with MRD negativity being a good surrogate for better long-term outcomes, and achieving that can be possible by offering an early transplant. And clearly, we are seeing across the board that attaining that MRD negativity should be the goal, and which can be accentuated by using transplant in the upfront setting. So let's talk about the next generation flow. The next generation flow had a lot of deficiencies. There were no standardizations that were done, and the sensitivity varied across. So what the Euroflow, or the panel that was that created the next generation flow, used optimizing the process at 3 different levels, using the optimal reagents, 2-tube, 8-color, to use the best possible colors, going on to optimal sample processing using buffer lysing, and with a target of obtaining more than 10 million cells for evaluation, and going on to using these novel strategies with these softwares for better gating, and you're able to attain this NGF receiving a sensitivity of close to 10 to the power of -6, on par with what you see with the next generation sequencing. And this has been proven in another prospective trial, in the Cassiopeia trial, using a daratumumab plus VTD versus VTD. And in these patients, 64% of the patients were MRD negative at the time, MRD negative at the threshold of 10 to the power of -5, compared to 44% with the VTD arm. So clearly, we made a case with the meta-analysis, we made a case with prospective trials, that MRD negativity has been shown to be prognostic. Now, moving on to the mass spectrometry methods, the advantage of a mass spec method is it's a blood-based test. So Mayo Clinic has used this to look at the impact of, or the prognostic impact of mass spec across all different, across patients on the Stamina trial. To bring you up to speed, Stamina trial is a trial that was originated in 2007, and patients had 3 arms. The first arm would receive transplant, followed by an auto transplant, followed by a tandem transplant, followed by len maintenance. The second arm would receive a transplant, followed by RVD consolidation for 4 cycles, followed by len maintenance. And the third arm would receive a single autologous stem cell transplant, followed by len maintenance. And here are the results across all patients. And these patients were tested post-induction, pre-maintenance at 1 year. And across all, as you can see, across every aspect, every panel that you see, the achievement of mass fix is prognostic for post-induction, pre-maintenance, and 1 year mass fix negativity, and which is exactly correlating with the serum immunofixation, the CR rates, and the MRD rates as well. As you can see, MRD rates are much more robustly prognostic at 1 year MRD, at 1 year of testing. So we'll put together the mass fix and the MRD status. Patients who achieved a mass fix and MRD negative are the ones that fared the best in the long run, suggesting that these tests could be complement to each other. So now, how can we compare and contrast between these 3 tests that we have? So of course, we use the serological testings with immunofixation to give a glimpse of what exactly immunofixation negativity means compared to the mass spec negativity versus the NGF negativity. The trial that we evaluated was from the GEM 2012 trial. This is 458 patients who received RVD for 6 cycles, and they were randomized to receive. It's a conditioning regimen of MEL200 versus BuMel, but patients would receive a consolidation with VRD in both arms. So post-induction, post-transplant, And post-consolidation, patients would receive both the bone marrow biopsy techniques to assess for MRD and the blood-based technique of the mass spec. So, but if you look at the number of people who still had residual disease by testing with immunofixation, it came down to 25%. With mass spec, you're still able to measure this residual disease at 34%. And with NGF, they were able to measure this residual disease at 43%. So the study had a second randomization as well. Patients who would receive, who would complete this consolidation would undergo randomization to receive RD for 2 years, and in arm B, they would receive ixazomib and RD for another 2 years. If the patient is MRD positive, the patient would receive RD for 3 years in both arms. If the patients are MRD negative, they stop treatment. So yearly evaluations of MRD are done. So if you look at the PFS according to all these three techniques, immunofixation positivity versus immunofixation negativity still was prognostic, as you can see from the curves, but this is not statistically significant. From a mass spec perspective, yes, the p-value is 0.0016, the hazard ratio is 2.18, and the median PFS was not reached for those patients who are mass spec negative, but it was 4.43 years that were mass spec positive. If you look at the NGF, so again, the median PFS for those patients that are positive on NGF is 4.43 years, and the median PFS was not reached. Hazard ratio was close to 3, and p-value is significantly different. So if you combine those patients that achieve the MRD negativity continue to do well over the long run, both for the PFS as well as the overall survival. And mass spec and NGF could be complementary in a setting like this. So the study, as I talked about the second part of the study, it also asked the question of can we interrupt a prolonged treatment based on the MRD positivity or MRD negativity. So those patients who are MRD negative here continue to be in remission for a longer period of time after stopping treatment, but however, much longer follow-up is needed for us to see that these patients are not dropping down with time without treatment. So that is again, longer follow-up for these trials will help us to make the right decision for the patient. It brings to another good trial, which clinically has used the same MRD testing in different contexts. So I'll give you a brief outline of this study. This is a master trial, used induction treatment with dara plus KRD, very effective induction regimen. Patients would receive MRD after completing 4 cycles of induction. They would receive a transplant. Again, another MRD is tested here. What happens here post-transplant is patients could drop off if they remain MRD negativity, going on to a treatment-free period. If the patients are MRD positive, they would receive blocks of cycles as a consolidation of 4 cycles of KRD. They remain MRD positive at 10 to the power of -5, they receive another consolidation with dara plus KRD and go on to Len maintenance. So this is a trial that showed that patients who had high-risk cytogenetic abnormalities, if patients had 1 high-risk cytogenetic abnormality versus 2 risk versus no risk, the patients continue to do well across the board, that the patients are able to get a good response. If you're looking at the by NGS, MRD 10 to the power of -5, and below panel are the ones MRD 10 to the power of -6, you're able to attain good responses across the board, even though numerically these are slightly lesser for those patients with high risk, 2+ high risk cytogenetic abnormalities, but clearly showing that it is possible to achieve those remissions. What is more interesting here is those patients that had 2+ high-risk cytogenetic abnormalities are the ones that started dropping down here in the PFS curves. And clearly the take-home message from this trial that I can see is these are the patients where you should not be able to give a treatment-free period or leave them on observation. These patients who have 0 high-risk features or 1 high-risk feature potentially this is a group that needs further long-term follow-up to make that right determination whether these patients can be safely stopped off on treatments. So again, the overall survival curves are exactly suggesting what we just discussed. So there are several ongoing trials using MRD adapted treatment modifications, the MIDAS trial, the Perseus trial. These are the patients where the decision is made based on the MRD positive status after the initial induction therapy, and MRD negative subjects in MRD positive MRD negative subjects in Perseus trial will stop daratumumab after sustained MRD negativity for 12 months and after a minimum of 24 months of maintenance. So similarly, AURIGA, the DRAMATIC, and the optimum studies are evaluating in the maintenance phase for the MRD conversion at 12 months after the intervention in the AURIGA trial, and DRAMATIC is going for a long run from the SWOG group with overall survival as the endpoint. There are other trials that are included. We just had a discussion about the master trial. So now switching gears to talking about how can we make the MRD much more robust by including the PET scans. So if you look at the variables of the hematological correlation of the responses compared to the MRD and the PET, you're seeing a total of 50% of the patients would achieve 10 to the power of -6 MRD negativity among all these 240 patients that we tested. If you look closely at those patients who had a stringent complete response, 2/3 of the patients remain MRD negative if they obtain a stringent complete response at 10 to the power of -6. This number increased to 3/4 of the patients remaining in MRD negativity at 10 to the power of -5. And at 10 to the power of -4, these are 90% of the patients. So PET negativity was seen in 69% of the patients. So now if you look at them individually, so the PFS by the MRD threshold level, the patients who did not progress are the ones who achieved at least 10 to the power of -6 or 10 to the power of -5. Patients who progressed are the ones who achieved 10 to the power of -4 or greater than 10 to the power of -4. If you look PET as a single univariate independent variable of PET positivity versus PET negativity, patients who did not progress are the ones who are PET negative. So this PET by itself is a robust prognostic marker if PET negativity is achieved for PFS. So now if you put all of these into the multivariate models, so those patients who had a PET positivity had a hazards ratio of 4.08. And if you look at the RIS's stage 3 disease, had a hazards ratio of 11.62. And if somebody has an MRD positivity at 10 to the power of -4, they have a hazards ratio that is of 17.42. And this is much worse than what you expect with an RIS stage 3 disease. So can we isolate those patients who are MRD positive at 10 to the power of -4 to tease them who could do much better in the long run versus not do as well? If you look at the left slide, the PET positivity and PET negative and MRD at 10 to the power of -4, negative at 10 to the power of -4, they continue to do very well here. Probably this is the group of patients who are PET and or MRD at 10 to the power of -4 positive. This group is the one that potentially could be targeted for escalating treatments to bring them to a PET negativity and an MRD negativity state. So going back to our patient cases, our 66-year-old male who's on LEN maintenance have not stopped the maintenance for a reason. Number one, gathering more and more information. When people ask me, what are you going to do with this data? The more data that I have before we make the treatment decision, the better it will be for the patient's long-term outcomes. Again, all the trials that I reviewed earlier are giving us ample data, which would be mature over the years, where it can help us to make this decision. When this patient was MRD positive in February of 2018, a year after the transplant, could we intensify on the treatments so that we can prevent these cascade of events downstream? So if you're making any decisions, those are not data backed. So that is a main issue, or wanted to highlight that as an aspect that we need to take into consideration for obtaining the most optimal outcomes for our patients backed by data. So to conclude, attaining MRD negativity is prognostic integrity threshold 10 to the power of -6, 10 to the power of -5, 10 to the power of -4, as well as attaining PET negativity in the newly diagnosed multiple myeloma patients. PET combined with MRD increases the robustness of these prognostic models, and attaining inability to attain MRD negativity of at least 10 to the power of -4 so holds similar or worse hazard ratio for progression as the RIS stage 3 disease. These technologies that we have today, the next generation sequencing, the next generation flow, the mass fix, are complementary to each other. So one of them should not be preferred as the better or the other in the absence of comparative trials showing the benefit of one or the other. So while attaining MRD negativity should be the goal, the MRD guided therapeutic decision making is still in early phases. There are several trials, as I reviewed, are in progress. And when we have most information from these trials, it would be much safer to make the decision for the patient. MRD as a regulatory endpoint, as a surrogate for both the PFS and the overall survival, is currently under validation with both European Medical Agency as well as the FDA, and we don't have any trials at this point that has been accepted and data is being pulled in to have this as a regulatory endpoint. With that, I'll stop. And here is my email address, anuka@emory.edu. I'd like to thank my myeloma team that works at Emory and have been a huge amount of support for us for the growth of a program. And if you have any questions regarding any data that I shared with you, I'm happy to send you the slides or happy to help you with any questions. With that, I'll stop and take care.